going to be on maternal hyperthyroidism and the fetus. And why I chose this is it's quite a rare condition in pregnancy, affecting I think just about 0.1 to 1% of pregnancy. And it's important because of the negative outcomes that are associated with the condition, both for the fetus and for the mother. Side effects are not very common when the thyroid is well controlled, but the effects come about when it's poorly controlled or when a woman has got thyrotoxicosis. Right, so my presentation is going to be on RC. She's a 39-year-old patient on the ward. She's para 3 gravida 4. Her estimated gestational age is 29 weeks. I apologize for the 29 weeks. And this is a woman who booked at 23 weeks gestation. And a bit of the background history is that this woman had been just sent for a routine scan from the clinic because her BPs were noted to be elevated. But on the request form, you notice that, in fact, there was no request form or no indication in the notes that this woman actually had hyperthyroidism or some form of endocrinopathy. So just to note that, I think this is what happens to most of patients sent to the FMU. They don't have a reason why the woman is being sent, and this was such a case. And again, in the history, this is a woman who on inquiry had been diagnosed with hyperthyroidism. So she had to Karanda with symptoms of thyrotoxicosis. She had tremors, she had heat intolerance, hair loss, and exomphalos. And again, of note is in the past 1 to 2 years, she had obstructive symptoms where she couldn't breathe, she was having hypersalivation, and she had a throat lump. And there was no diagnosis made then. But then when she presented to Karanda, they diagnosed hyperthyroidism and started her on carbimazole. And she had subfertility for 2 years prior to the presentation. So this is a woman who was started on carbimazole because of excessive symptoms of hyperthyroidism, but she did not know that she was pregnant at this time. And 4 weeks later, that's when she suspected she was pregnant. And this was 4 weeks after starting the carbimazole, and she had a pregnancy confirmed on ultrasound scan. And unfortunately, when she presented to the clinic, she was then asked to stop the carbimazole because of fear of congenital anomalies caused by the carbimazole. So of note is these effects are not unreal, but a woman with thyrotoxicosis is not supposed to be stopped on treatment. So this is a woman who was supposed to be referred, I think referral. There's no audio. I dialed over internet. I'm not muted. Can people hear me from there? You can hear me. And you can see my screen again. All right, so I was giving you a bit of the history of this woman. So I was now telling you that 4 weeks later, this woman was noted to be pregnant, and she had excessive symptoms of pregnancy. So I suspect that we know that in early pregnancy, between 6 and 10 weeks, there is a massive increase in the level of beta-HCG. And the structure of beta-HCG is very similar to that of TSH, and it stimulates TSH receptors. And so you'll notice that these excessive symptoms of thyroid disease were probably brought on by the elevated beta-HCG levels. This is why she was then diagnosed of acute hyperthyroidism at this time, because she was pregnant. Anyway, I was also saying that she was stopped, the carbimazole was stopped. And it's true that these anti-thyroid drugs, the carbimazole, the propylthiouracil, they do have adverse effects on the pregnancy. More so carbimazole, it's thought to be associated with what we call aplasia cutis. I'll discuss more of it as we go on. It's associated with some other congenital anomalies, like duodenal atresia, esophageal atresia, and urinary tract malformations, especially in the male fetus, VSD, facial dysmorphism. And so to balance this, traditionally women have been started on propylthiouracil in the first trimester because it's less teratogenic. Then after the first trimester, you know that women are then put on carbimazole because of its convenience. It's once a day dose, and also it's less likely to cause hepatotoxicity compared to propylthiouracil. So the learning point here was this woman, when she was seen at the local clinic, maybe should not have been stopped on drugs, but rather referred for ongoing care, and her drugs are managed appropriately. And I've noticed she had no thyroid disease in her past pregnancies. So I think that's it about the history of this patient. So how then we came to know in the FMU that this woman might have thyroid disease, there was an incidental finding of a fetal tachycardia. So when we measured the fetal heart rate during the biometry, the heart rate was persistently ranging between 167 and 178. And so we recorded this as a fetal tachycardia. We noted that the woman had no fever at that time and no other conditions that were likely to lead to this. So we then booked for Dr. Verenga to redo the scan, as we got a history of possible hyperthyroidism in this patient. And also because we're not getting good biometry, that's why we then said, okay, let's book for the specialist clinic for Dr. Verenga to assess this patient. In the meanwhile, we admitted, she was coming from home, so we admitted her. We started her on propranolol. We requested that blood be done for thyroid function test, for liver function test, and the routine labs. Unfortunately, these haven't come back yet, obviously because of financial issues, but we are waiting. So far, she has not been recommenced on the carbimazole. She remains on propranolol. And so this heart rate that we see here, it was 157, and this was 3 days after commencing this patient on propranolol, which is a beta blocker. The picture we see on the left is of the fetal abdomen, and you'll notice that I had said that this patient was 29 weeks, and you'll notice that this biometry is showing that the baby had a growth that was at the 13th centile. So there was a reduction in the abdominal circumference at 231.2 millimeters. And in the next image, that's the fetal head. We had so many issues trying to really locate the fetal head and to assess the structures of the fetal head to see if they were normal. So hence the referral. And it was a bit difficult to localize the structures in the brain. But on the left, you'll see that Dr. Verenga managed to measure the ventricle, and it was 0.89 centimeters, which was within normal. And also the biparietal diameter, he was able to measure that for us, as well as the head circumference shown in the next slide. And you'll notice that the growth of this fetus, the biparietal diameter was at 73%, the head circumference was at 23%. And in the next slide, you'll see the biometry of the femur. And again, this shows that this fetus was growth restricted, with the femur length being less than 1%, being less than 1%. And I put the image on the right to show that these patients, these fetuses where mothers have got maternal hyperthyroidism, can have accelerated bone age. though we did not demonstrate this particular feature did not have accelerated bone age, but it's something that we're supposed to look out for. And Dr. Renga, I stand corrected, but I noticed that on the right, there was an epiphysis which was visible at 26 weeks, which is not the norm. So we're not supposed to be, and I chose that one at 26 weeks because it was comparable to the gestational age that we have now. So of note, you know, in a hyperthyroid fetus, they have accelerated bone growth, which I tried to, and which is not demonstrated on the image on the left. Then this next slide is actually basically a summary to show us that this fetus was growth restricted because of the maternal hyperthyroidism. You'll notice that the BPD was the only parameter that was 73%. All the other parameters were showing a growth restricted fetus. That means that is the fetus affected by the maternal hyperthyroidism. And on the next slide, this I put for you to see that the placenta had matured. So we had a grade 3 placenta on a fetus that was 29 weeks old. And so you see that there's placental dysfunction probably because of the gestational hypertension and the hyperthyroidism itself. And again, the next slide is showing a mature placenta, a sign of disease in the fetus, and there's the median profile of the fetus that measured the nasal bone, which was normal at 0.68 centimeters. So, and so this was normal, and the facial profile was normal. We proceeded to do umbilical artery Dopplers for this fetus, and you find that the umbilical artery pulsatility index was 1.21, but this was actually normal for this gestational age, according to the graph, the obstetric graphs. This was normal. And this is a Doppler of the uterine artery, again showing a normal waveform of the uterine artery and the PI of 0.66, a PI of 1.13, again normal on the graph for a fetus of this gestational age. And you notice that there was no notching in this picture. Then that's of the left, of the right uterine artery, again normal indices recorded there. Then we do not expect to find abnormal or neural tube defects in patients. Sorry, we don't expect to find spina bifida in fetuses affected by maternal hypothyroidism. But of note is that when they are started on drugs, it's important to look out for omphalocele. We ruled that out on the image with the abdominal circumference. They do get omphalocele as a result of the drugs given, like the antithyroid drugs. And this fetus had no neural tube defect. You can see the spine is normal, and that railway slipper appearance is normal. I put that slide up to show that, again, this fetus had a normal single deepest pool. And we have to look out for this because fetus is affected by maternal hyperthyroidism, can actually get oligohydramnios and polyhydramnios. So it was important to note that in this fetus, these features were not there. And we assess for these things because we know that when a mother is affected by hyperthyroidism, the thyroid hormones, the TSH, crosses the placenta to affect the fetal thyroid. And so the fetus can actually be, especially if the mother has got TSH receptor antibodies, normally labeled as TRAPs. If the mother has got these antibodies, especially if they're 3 times above normal, the fetus is likely to suffer from hyperthyroidism. So it's important to monitor the fetus of a mother with poorly controlled hyperthyroidism for these features. And again, the heart, there's the 4-chamber view of the heart, and it looked normal, as with color Dopplers of the heart, they were also normal. Then often of particular interest, obviously I couldn't do this at my level, so we referred to Dr. Verenga to check the fetal thyroid for us. As I've been saying, the fetus gets affected, gets thyroid disease because of maternal hyperthyroidism. And you notice the image on the left is the image taken by Dr. Verenga. And you'll notice that the fetal thyroid is not prominent in this neck. It was actually a difficult image for him to get because of the position of the baby. But you'll notice that there's no thyroid that is noticed on the fetus. And I forgot to give you if it was written somewhere. This is the borrowed image on the left, where you'll notice a swelling, a lump on the neck indicated by those two arrows of a fetus of a similar gestational age affected by hyperthyroidism. So you notice the difference, and the fetus in our case is not affected by this. This is the courtesy of, I've forgotten the credentials. Then on again, and I've seen Dr. Verenga reconstructing 3D images of the fetus. So if he had constructed a 3D image of this fetus, a fetus with a goiter would look like the one on the right, but on our fetus we did not, probably because there was no visible goiter. We did not construct or reconstruct a 3D image of the fetus, but that's how it would look if the fetus was affected by the maternal hyperthyroidism. And this is important because it has effects not only, so this can be caused actually by the hyperthyroidism itself or by the drugs that are given to control the thyroid disease. So you notice that when these women are treated, you keep the T4, T3 levels at the upper levels of normal. So some texts would say 1.4 to 1.5 levels of normal. And this is so to prevent fetal hypothyroidism, which is equally an adverse event for the fetus, because if the fetus gets hypothyroidism, especially we know that the fetal thyroid starts to work between 5 to 6 weeks, and then by 10 weeks, it's actually secreting thyroid hormones. So if the fetal thyroid is then affected at this age, the fetus will suffer from criticism. So it's equally important to make sure that when we control the thyroid disease in the woman, we leave her hormone levels at the upper borders of normal to allow thyroid development in the fetus. And I think that was my last slide. And the pregnancy care plan so far. So right now we're waiting for this patient to have thyroid function test. She will have these today. And in Zimbabwe, I'm not too sure if we're able to carry out TSH receptor antibodies. These have got they're important in prognostication for the fetus. So this woman, we intend to carry out 2 weekly scans in her to check for fetal well-being and for fetal growth. The BP remains controlled on antihypertensives, and right, we're hoping to put her back on treatment, particularly if her symptoms don't develop. And obviously, we will be on the lookout for adverse events. We'll be monitoring the document and echo. They're at risk of CCF, they're at risk of severe hypertension and of stroke. So the BP needs to be well controlled, and we need to make sure she doesn't get into heart failure. And also at birth, we must be careful, we must be on the lookout for complications such as thyroid storm, which can be brought about by labor itself, which can be brought about by infections, if she needs a cesarean section. So this is a woman who needs a multidisciplinary team management. She needs a review by the physicians. The physicians have seen already. So she needs a review by the physicians. She needs an anesthetic consult if she's going to get into theater. And she needs her thyroid function test monitored in each semester. And of notice, sometimes in the 3rd trimester, you may need to actually stop these antithyroid drugs as they may actually be a spontaneous lowering of T4, T3 in the 3rd trimester. So yeah, she needs MDT management, 2 weekly scanning to assess and control of the disease. That's the plan for this woman. I have finished my presentation. Thank you. So anyone with any questions? Dr. Weringa is ready to answer. Okay, if I can answer, I will answer. I'd be happy to answer anyone with questions. Okay, you said we may need to stop. So this depends on what I've said. We monitor every trimester, sorry, the thyroid hormones. So sometimes there's a tendency for a spontaneous reduction in the T3, T4 levels. I think it's because of this. I'm trying to think why we need to stop, but I know that there can be a spontaneous lowering of the T4, T3. And so a woman can actually be hypothyroid because of drugs if you continue treatment. It's probably to do with some physiological change that happens in pregnancy, but I will double check. Dr. Weringa, I don't know if you can help.
Probably, yeah, probably can double check and
update. Okay, I'll do that. Any other questions?
Any questions, guys, from the floor? It appears like Dr. Ziki has done an amazing presentation, and no one has a question to ask her. Is that correct? So if there are no questions, probably we may need to conclude the meeting, isn't it? We may need to conclude the meeting. Thank you so much. This afternoon, Fetal Medicine Unit is presenting in the department. Dr. Gaza will be presenting one of the cases we saw at Pari with increased nuclear translucence above the 99 cedal. So that's what Dr. Gaza will be presenting at the 12 o'clock meeting. The department, the unit of obstetrics and gynecology meeting. So please tune in, and it's a very interesting case. We are still managing the case. It's not yet delivered, but please tune in at 12 o'clock to hear Dr. Gaza's present on this case and also the management. I expect you guys to answer the question. Dr. Dagura, Dr. Farah, and Dr. Rachwayo, I'm expecting to answer the questions that will come from the audience concerning the issues of nuclear translucency. So please join into the meeting so that you can answer the questions that will arise from various participants today between 12 and 1. Thank you. Unless if there are no questions, I think we can simply end the meeting.
Morning, Dr. Weringa. Hello. Yeah, I would suggest that Dr. Gaza shares the history of the patient on the group so that we are all in the loop.
Perfect. So Dr. Gaza, I think you can hear it. She's in the meeting. Dr. Gaza, you can hear this. Just share your presentation on the Zoom feature group so that everyone can go through it and be prepared to answer the question that you may not be able to answer. Okay?
Okay, noted. I'll share.
Thank you so much. Thank you. Great. So yeah, thank you so much. And next week we continue the presentation. Dr. Gaza will present on Friday again, depending on the cases that will meet during the week. So yeah, so thank you so much, and let's keep on going. The outcome collection will start soon. I think Monday will be able some researchers who come to learn Fetal Head so that they can start the data input, the outcomes, because we have a lot of lagging outcomes if you want people to start completing. Thank you so much. And let's continue to book the 11 to 13 week scans, because that's the basis of fetal medicine. People need to understand the 11 to 13 week period. What is it for, and what should be done in that period? We can only do that if we have patients to see. The presentation will be shared. It will be on the YouTube. The FMF Foundation ladies are recording it, so they will send the link to the YouTube channel where it can be watched over and over again. Even last week's presentation, it's also on the group. I'll ask them to send me the link so that I can share with you the link. The one that done by Dr. Gaza is also on the group. Even the afternoon one today, we'll make sure it's recorded as well. Thank you.
Thank you.
Bye-bye.